So here I am today with Dr. Kamdar, and we're going to be talking about ASCO 2023 and the hot topics that everyone was talking about in lymphoma. Dr. Kamdar, could you give us a little snapshot of your research interests and maybe a little bit about your career history to date?
Sure. Thank you very much. Pleasure to be on this podcast. My name is Manali Kamdar. I am an associate professor at the University of Colorado Cancer Center. I'm a hematologist, oncologist by trade, and I specialize in lymphomas, and I primarily specialize in doing clinical trials focused on cellular therapies. So at this year's ASCO, I think we had a lot of data, but some of the data is actually practice changing or has the potential to be practice changing. Since cellular therapy is so dear to me, maybe I will start off with some of the updates in cellular therapy. So, as we all know, CAR T cell therapy targeting CD19 has changed the outcomes in patients with relapsed refractory diffuse large B cell lymphoma. Previously, patients who could not achieve a remission after an auto transplant could not get to an auto transplant. The FDA approved CAR T cell therapy, namely Axi-cel, Liso-cel, as well as Tisacel in the third line setting. And with the help of CAR T cell therapy, we were able to salvage nearly 40% of patients who would have otherwise succumbed to their disease. CAR T worked post auto transplant, so it was intuitive to test it in the upfront setting in terms of bringing it forward. So, thus was the birth of three randomized clinical trials, namely ZUMA-7, testing Axi-cel versus standard of care, Transform, testing Liso-cel versus standard of care, and Belinda, testing Tisagenlecleucel versus standard of care. All of these three phase 3 pivotal studies were tested in patients with high-risk relapse refractory diffuse large B-cell lymphoma. Not all relapses are created equal. We do know that patients who are primary refractory or have relapsed within the first year of receiving rituximab plus chemotherapy have an exceptionally poor outcome, even with an auto transplant. So these studies were primarily tested in transplant eligible individuals. And the net is that two of these studies were positive. The primary endpoint of event-free survival was met. It was statistically significant and superior with regards to Axi-cel and Liso-cel as compared to standard of care. What was very, very promising and important to highlight at this year's ASCO meeting was the fact that there was now a follow-up of the ZUMA-7 study, and there is now emerged an overall survival benefit. On the ZUMA-7 study, crossover was not permitted on study, but it was permitted off protocol. So people on the standard of care arm who did progress were able to get Axi-cel off protocol. So with that in place, it's actually really important to highlight that for this high-risk relapse refractory subset of diffuse large B-cell lymphoma patients, it's really important to refer them to a CAR T-cell therapy center. It definitely establishes, in my mind, the role of CAR T-cell therapy as a second-line therapeutic option in patients with primary refractory and relapse within a year diffuse large B-cell lymphoma. So that was the update with regards to ZUMA-7 and CD19-directed CAR T-cell therapy in diffuse large B-cell lymphoma. The second update came in the form of Lisocabtagene maraleucel. This is also a CD19-derived CAR T-cell therapy product. It differs from Axi-cel in terms of its co-stimulatory domain, 4-1BB in Liso-cel, CD28 in Axi-cel. There are other subtle nuances as well, but that's primarily the highlight. But Lisocabtagene maraleucel was actually tested in the Transcend CLL 004 study and relapsed refractory chronic lymphocytic leukemia and small lymphocytic lymphoma patients. And this was the primary analysis of the study. Extremely important to highlight that patients actually did really well. The overall response rate was 43%, and the CR and CRI was 18%. It seems sobering, but remember, it's by the IWCLL criteria. I think within CLL, we have clearly moved beyond the definition of IWCLL. We absolutely are aware that MRD is very prognostic, and it's important to highlight that the MRD rate on this study was upwards of 50%. The grade 3, grade 4 toxicities were very manageable. Grade 3 neurotoxicity was 18% at this point, Overall, I will say the duration of response is very promising at 35 months. So the big question is, will Liso-cel finally get its approval for patients in the relapsed refractory CLL study? In the relapsed refractory CLL setting, I think, once we get some information from the regulatory bodies, we would be able to understand if this could be a potential third-line option for patients who fail a BTK inhibitor and a BCL2 inhibitor. As we know right now, we have BTK inhibitors for patients with CLL, BCL2 inhibitors for patients with CLL, but we certainly have a subset of patients with high-risk CLL who fail both of these agents. I think for that subset, Lisocabtagene might actually prove to be very, very useful. Besides, of course, the non-covalent BTK inhibitors like pirtobrutinib, which I'm hopeful will also receive approval. I think the third study that I'd like to focus on is clearly a potentially practice-changing study. This was the SWOG study, SWOG 1826. It was presented by Alex Herrera and colleagues. I am part of the SWOG group as well. So we are very delighted that on behalf of nearly 1,000 patients, this study was presented. This is a randomized study which in patients with advanced stage Hodgkin lymphoma. These patients were not just adults, but also the AYA population. The children's group also contributed significant amount of patients for this study. This was basically a study randomizing brentuximab plus AVD, which is the current standard of care for advanced stage Hodgkin lymphoma, versus Nivolumab plus AVD. And I think the net is that the progression-free survival was the primary endpoint, and at the 1-year mark, it was met. 1-year progression-free survival was over 94%. On the other hand, it was in the 80s for AA plus AVD. Important to highlight that even though there is no overall survival difference yet, the toxicity profile was very encouraging. There were no immune-mediated toxicities of high concern on the Nivolumab plus AVD arm. They were all manageable. Neuropathy rate was significantly higher on the brentuximab arm. Neutropenia was higher on the Nivolumab plus AVD, but it did not translate into febrile neutropenia. Overall, I think this has the potential to change primary therapy for advanced stage Hodgkin with the incorporation of PD-1 inhibitors to the chemotherapy backbone. So overall, I think these were probably the key abstracts that come to mind. Besides, there were also a few others. For example, there was the follow-up of the Lima study. Just to quickly refresh the memory of our audience here, Lima study is a study in frontline mantle cell lymphoma patients. So young transplant-eligible patients were taken to a transplant, and after transplant, they were randomized to either getting rituximab maintenance every 2 years, every 2 months for 3 years, or placebo. And at the 3 or 4 year follow-up that was presented a few years ago, it did show that not only was rituximab beneficial in making it improve progression-free survival, but there was a distinct overall survival difference. What was really interesting about this 7-year follow-up of the Lima study, that the progression-free survival continues to be superior on the rituximab arm. However, there is no longer an overall survival difference. It's very intriguing. It could either reflect the fact that people on the observation arm are progressing, but may not be dying because of more treatment options that are now available, because of which maybe the overall survival benefit has gone away. But nonetheless, I think the bigger question now in clinical practice is how much shall we truly push rituximab maintenance in our post-auto transplant patients? As we know, most of them will tolerate it fine, but this discussion is very similar now to people with indolent lymphomas like follicular lymphoma, where rituximab does cause a significant progression-free survival difference, but has not elicited an overall survival difference. So I think that discussion remains quite similar for mantle cell lymphoma. So for me, the net is that if someone is having neutropenia because of autoimmune neutropenia secondary to rituximab, is having lots of sinus infections, upper respiratory tract infections as a result of the hypogammaglobulinemia, I'm probably not going to push rituximab for those patients post-auto transplant, considering that the overall survival difference is now no longer there. So I think these were the key abstracts that certainly made me take notice at the most recent ASCO 2023 meeting. I think in the next few months, in the next following conferences, I think there is a lot of data with regards to cellular therapy, immunotherapy, for example, bispecific T-cell engagers targeting CD20, like epcoritamab, glofitamab, mosunetuzumab. I think these are all going to be moved ahead in the treatment algorithm in not just diffuse large B-cell lymphoma, but also in follicular lymphoma. So I think the therapy options exist. They are increasing. Our toolkit is continuously growing. I think we really have to figure out a way now to sequence better in patients with indolent lymphoma. And for our patients with aggressive lymphoma, I think we really need to make sure we have our goal to cure everyone. And I think that can only happen with a clinical trial in place. So with that, I'll come to the end of this podcast. Thank you very much for having me.
Thank you so much, Dr. Kamdar, for an amazing summary of lymphoma at ASCO 2023. We're really grateful for your time and a snapshot of what sounds like an amazing conference. Thank you.
Thank you.